Welcome back to the Blood and Guts podcast. My name is Dr. Stephen Cohen, and we have a very special guest today, which is a little bit different than who we normally talk to in talking about medical legal things, about expert witnessing, about talking to attorneys. But I read an article by a Dr. Drew Remignanti. I'm going to work on that name. I'll get it by the end. About some of his experience. He has been a physician longer than me. He is an emergency room physician, or was an emergency room physician. And he wrote a very interesting book that I think all of my listeners need to hear his perspective of where he's coming from. So thank you so much for being here. Dr. Remignanti, can you just introduce yourself and just tell us a little bit about who you are?
Thanks again for inviting me on, Stephen. I'm retired in April of 20 after a 40-year career as a board certified emergency physician. And the other day I found myself in the midst of saying that sentence, either I was or I am an emergency physician. I decided I am an emergency physician, comma, retired. The was sounded too past tense because that's sort of been my identity. I still maintain the identity of being an emergency physician. So,
Excellent. And just give us a little bit about your training. Where did you go to medical school? Where did you train? And where did you work mostly for that 40 years?
I was down in Florida, in Jacksonville, Florida, for my emergency medicine residency. And I'm kind of an old timer in emergency medicine. I was in emergency medicine residency from 81 to 83 when it was just a 2-year residency. It was based on 3 years. You had to do an internship somewhere else. I did an internal medicine internship with the expectation that I was going to look into emergency medicine for my residency. Nowadays, it's a 4-year program, and most programs provide all 4 years for you. So it was interesting because a number of people in my medical school or my residency year were from the Northeast, like I was, either Massachusetts, I was originally from New Jersey, guy from Pennsylvania. And so we're all in the North. We wanted to go back and work in the Northeast because that was our home region. And our faculty was saying, no, you don't want to do it. The Northeast is a backwater for emergency medicine. There's really nothing there. There's the South, there's the Midwest, there's the West. There is nothing in the Northeast. And they were right, there was nothing in the Northeast. So we got this bold idea that we will become a group and we'll sell ourselves to a hospital in the Northeast. There were only 6 of us. So we wrote a letter to basically every single New England hospital, all the way down to a couple in northern New Jersey. We didn't go any further south than that. And we ended up selling our services to a very small hospital called Toby Hospital in Wareham, Massachusetts. We basically took over their emergency department. And so one of your questions about, well, who my mentors were in emergency medicine, there were no mentors then. We were sort of inventing it on the fly. It was a great learning experience to kind of be part of the creation of a new specialty. I like to say, coming in 83, we didn't build the House of Emergency Medicine, but the House of Emergency Medicine was an addition on the House of Medicine. But we got in while the paint was still drying on the walls,
Right. Yeah. And things have changed in emergency room medicine now. It's a whole different field, as you know. So tell me, what prompted you to write the book that you wrote? And tell us a little bit about that journey.
Well, I became board certified in emergency medicine originally in 84. Then I recertified in 94, 2 years after I had my stroke. And again in 04, 14. And the chief, I said, if I have to recertify in 24, I'll be 72 years old. And that's probably, I'm going to be a hazard to my patients. So maybe recertifying again in 2024 is not in the cards for me. So I decided on 2020 as a nice round retirement year because I graduated medical school in 80. And then I said to myself, well, gee, I'm going to be retired in 20, and there's no way I'm going to stop thinking about medicine and healthcare. I can stop practicing, but I won't stop thinking about it. Then I thought I might have some observations to offer to people, both based on my work career and my patient career. Referred to as my patient career because I had developed a lifelong autoimmune disease at age 19. So I've had a I've been patient longer than a physician.
Yeah, how have you tell me about that? Because we all as we all get older, me included, we have health issues, me included. And personally, I became much more empathetic when I became a patient, seeing what it's like on the patient side.
That was a no doubt a help for me, I think, too.
Right,
Of course, when I got sick with ulcerative colitis at age 19, I was told I was just told it was a chronic disease for which there was no cure, but that there
right,
would be exacerbations and remissions. In my particular case, I never went into remission, so I was chronically active for basically, well, for the ulcerative colitis for good, closing in on 10 years when they said to me, hey, now you're at the stage, Drew, where your risk of cancer of the colon is increasing every single year. I was
correct.
married, I had a 2-year-old child, and I thought, well, I certainly don't want to go that route. They said, well, we can scope you every year. Like when I had a colonoscope the day during the day, I had went for night shift that night. And the guy said to me afterwards, um, Drew, I biopsied a number of areas and I don't think any of it is cancer, but frankly, your colon looks so horrible. We could easily overmiss. We can't die, we can't biopsy the whole damn thing. And you're probably better served by having your colon removed. Kind of a big time decision at age 28.
Right. No, absolutely. Where were you in your training at that point? At age 28, you were working, correct?
I was at age 28. I was in my second year, second year, my PGY2, postgraduate year 2, which was my first year in Jacksonville, Florida.
Right,
I took the summer off between my PGY2, PGY3 years and came back up here to New York City because the guy who was doing the surgery that I wanted to have done was at Mount Sinai in New York City, which was convenient because my family lived in northern Jersey. That part was convenient.
yeah,
And,
excellent colorectal surgeons in that facility.
yeah, so
Absolutely.
that was a big time decision. I don't regret it. And in a sense, as the surgeons told me it would, it cured me of my ulcerative colitis because you can't have
Right,
colitis without a colon.
right,
But what it doesn't cure, it doesn't cure the underlying autoimmune process,
right,
which, and then I ended up having a stroke 10 years later, which they attributed to a coagulopathy from the ulcerative colitis that I had been cured from. So that was
right.
kind of a major kick in the teeth. Now I'm in stage 3 of my chronic autoimmune disease because now the same autoimmune process is attacking my liver. So I have what's called PSC, primary
Right.
sclerosing cholangitis. I'm back to being screened for cancer again because that's another potential cancer. So,
Right. Well, tell me about the patient-doctor relationship as you've seen it change from when you were a house staff or a junior attending versus now. What is the big difference?
well, in emergency medicine, we don't have the benefits of seeing our patients in a sustained fashion. So I saw it mostly from the patient end, which is, um, I think, and the title of my book was The Healing Connection, a Partnership for Your Health, because I think we need to reconceptualize the patient-physician relationship as a true partnership. It's not an equal partnership in the sense that we don't have we don't come up with the same skill set like you would if you were in practice with another colorectal surgeon, you'd be equal partners. But my expertise as a physician is, or our expertise as the physicians is what's in your best interest for your health. And your expertise is what you're experiencing as a patient and trying to convey that to me as accurately as you can. And I say to people, as a patient, you have to come in with a full-throated commitment to the process. The nature of our business is your health. I can't be the one who delivers your health to you. I can help you sustain and regain your health, but if you're not totally committed to the process, it's just not going to happen. It doesn't. And in emergency medicine, we see a lot of people who come in looking for the quick fix.
Right,
For a lot of conditions, there are quick fix. One of my favorites to see is a shoulder dislocation. You
right.
come in and I can pop that back in place with your cooperation and you feel tremendous and I feel great for having done you a service. But there are very few quick fix medical problems.
Well, let me ask you about that. Do you think from year 2010 through when you retired 2020, which is a good 10-year period, that there was a change in the attitude or the entitlement of patients. And the
Yeah,
reason, because the reason I ask that is, a lot of my post-op patients, rather than call me if they're having an issue, or patients I know that I've been taking care of for a long time, they will, for whatever reason, sometimes want to get more care or a different opinion of their chronic condition in the emergency room. And I try to explain to them that they you there's no way. I mean, I have a history with you. I've scoped you multiple times. I've seen you in the office multiple times. I've ordered your labs, your x-rays. I've seen all that. The doctor there doesn't have any of that information. Why do you think that they might be able to help you anymore? So did you see a change in the last 10 years of entitlement or what patients were requesting of you?
yeah, but progressive worsening, it's came in, you know, I'm glad we're leaving the paternalistic model of healthcare behind, where we have the passive patient comes in and listen to you as you're the paternal figure. You're going to tell them what to do. You're going to fix their problem overnight, like their dad did when they were young.
Right,
We're not going to do that. Um, and so they come to emergency medicine because they know they don't have to wait to see you. They can see me right away. And
right.
sometimes I think because I'm not their doctor, they can boss me around a little bit more.
Right. Dr.
Like,
Cohen always does this for me. And then
yeah,
you go, well, I don't
exactly.
know. I don't know. Right. Right.
And so
Right.
it's a bad way to get your health care. It's good. It's a great place to be if you have a true emergency. And of course, most people are there because in their mind, it's an emergency because it hurts a lot or they want a quick solution. And they're being sold a bill of goods by a lot of people out there. There's this great reference in my book by this woman who's the CEO of a multi-billion-dollar healthcare organization with 30 years experience. And I could have forgiven her for saying this if she was 5 years into it, but she said, patients need primary care, but not necessarily a physician relationship. Yeah, I want to say, well, what? Basically, they want the physician out of the picture because they want to say to the patient, you get to get what you want to have, and we get the doctor out of the way so they won't keep you from getting what you want to have. And it's a whole consumer provider model. You're the consumer. The customer is always right. It's just not applicable to medicine at all.
Yeah. I mean, that doesn't make any sense. I mean, it's both of us have education, experience, and training. Um, that, it's almost like in the medical, I hate to relate it back to the medical legal world, but when I'm explaining complex issues to a jury, I mean, that's one of the reasons why the whole medical legal world doesn't make a lot of sense. You're being judged by members of your peers. Well, wait a second. For a jury who has very little to no medical information, they're looking at two expert witnesses, well trained, board certified, decades of experience, and saying exactly the opposite. One is saying this doctor met the standard of care. This doctor, they have the same credentials. This doctor said they did not meet it. How are they supposed to decide that? So now people are saying that the patients get to decide what they want. That won't bode very well.
Well, it's not going to end well. And
Right.
um, yeah, well, the thing that the false equivalence is there's certainty in a lot of things in life. Health and medicine is not one of those things in which you cannot access certainty at your will. You take your car to the shop, the guy can take it apart and tell you what's wrong and put it back together. And he's certain what's wrong because he looks at the spark plugs and says, these are garbage. Just put new ones in, your car will run better.
Right.
Medicine just doesn't work that way. But patients want it to work that way.
Yeah. Well, and I always say this all the time, patients want a guarantee. There is no guarantee in medicine. And when I'm going through my informed consent, even for a quote unquote minor surgery, which is there is no such thing, obviously, there sometimes when I say the word you can die, you go, but doctor, it's just my hemorrhoids. Well, you're undergoing general anesthesia, and one of the risks is death. So I think so. What do you think is going to happen in the next 10 years in terms of either artificial intelligence? Because I think what you're alluding to is if you get the doctor out of the way, is artificial intelligence going to take over?
I think that's what the people, the bean counters, the people who are pocketing money off the whole process would like. They'd like to either get rid of the doctor, replace the doctor with a mid-level non-physician provider, or ideally now with AI, which doesn't cost them anything except the cost of buying the program once. Really poor thinking. And the non-clinical people making clinical decisions, once we started down that avenue, it was, we're heading towards doom unless we reverse course. The idea that non-clinical people should be making clinical decisions is just, I mean, you wouldn't, if you were trying to send a rocket ship to Mars, you wouldn't say, let's fire all the experienced aerospace engineers and let's hire a bunch of people a year or two into their engineering training. You just wouldn't, you wouldn't settle for less. And we're settling for less in our healthcare, and we shouldn't settle for less.
Let me ask you a question about your thoughts, and maybe you don't have any experience with it. Did you have any experience with telemedicine?
Not providing it, I do, I occasionally now when I see my liver specialist who's down in Boston and he doesn't think I need to make the trip, and we've seen each other a couple of times, we know each other, we trust each other. Telemedicine, I think, has a good role in an established relationship for a stable condition in which you're revisiting. Your most recent labs showed this. This is what we should do now, Drew.
Right.
But there's a case just happened. Telemedicine should never be your first and initial contact for any complaint whatsoever. The guy who called into Amazon One Medical
I read that.
is
Yeah.
being sued because some guy, they didn't, 45-year-old guy, they didn't detail who he spoke with, but he tells them he's feeling short of breath, he's coughing up blood, and his feet are turning blue.
Yeah.
Any one of those alone means you need to be face to face with somebody.
Right.
They prescribe an inhaler for him over the phone, and he dies, of course. And telemedicine is a supplement. Telemedicine is a supplement. AI is a supplement. High tech of all kinds is a supplement to a face-to-face patient-physician interaction.
So it's interesting you say that. There's a couple of very large publicly traded telemedicine companies, Amwell, um, Teladoc. There's one more. I'm blanking on the name. I mean, even with my own insurance, if I wake up with pink eye, and I'm just making this up, I've never had pink eye. If I log into my Blue Cross Blue Shield online and I don't feel like going anywhere, I can, for a $25 copay, I can log in, I can do a video chat with the doctor, and if it looks like pink eye, they can send me some antibiotics. Having said that, if you look back at your emergency room career, and I've asked other doctors this question, what percentage of patients actually needed to be in the emergency room versus could have been seen by their primary care doctor?
I'd say it's about 50-50, frankly.
Wow.
I mean,
Yeah,
there's a lot of stuff that doesn't need to be. Everybody with a new complaint needs to be in front of a doctor, but me versus you, who knows the patient, is a bad choice in half the cases. Again, of course, if this guy who is short of breath, coughing up blood, and feet turning blue, he needs to be in front of me, not you.
right. No,
Certainly
absolutely.
certainly not in front of a telehealth. But
Well, sometimes what I have found is that, patients are reluctant they don't want to go to the emergency room. I mean,
understandably, if you
right.
can
I
avoid
mean,
it, it's
right,
avoidable. If you can avoid that experience, better
right.
power to you.
So, since I am involved in telemedicine in a lot of different various ways, I have sent patients to the emergency room, but don't want to go. I mean, they want me to diagnose appendicitis over the telephone and assure them it's not. And I'm thinking,
That's
you
just great.
got to be kidding me.
That's
That's
just
right.
great. No, that they've
Yeah.
been sold this bill of goods that it's okay just to talk to not even an experienced surgeon like you, just anybody.
Right.
Pretty soon they're going to be just talking to AI. There was a great guy published an article where he, at the end of his ED shift, he read in all his cases to the AI and see what they came up with. The correct, what he thought was the correct diagnosis was on those lists half the time. So half the time
Wow.
it was on the list. But the big miss was missing a case of a tubal pregnancy, because and what he had to read in was when the woman was asked was she sexually active, she said no. Could she be pregnant? She said no. So that
Well,
AI doesn't know enough to know that people are not going to necessarily tell you the truth.
right. Yeah, and that's a great point because again, you did this long enough. They don't, Doc, do you drink? No, not much. And the wife says, "What are you talking about? You drink six pack a day." It's like, but it's only one beer. Well, it's huge. It's a big beer, but yeah, I mean, yeah, it's trust but verify, and it's yeah,
You can learn so much from body language and the way people choose to express themselves, their tone of voice, how they answer a question. A lot of that, it's all lost, of course, if you're talking AI, and a good part
right.
of it's lost in telehealth. You know,
Well, so let me ask a couple of more questions. A couple of main questions is, as you've seen healthcare change over the last 40 years, as I have, what do you hope for the future?
well, I'm hoping I'm not optimistic that we will do it, but I think we can achieve great things if we take on the paradigm I'm talking about, where we want a true democratized patient-physician relationship where there's shared decision making. I respect your points of view as a patient. I don't then automatically dismiss them, but I don't feel obligated to adopt them just because you're the customer. My job is to question the basis for which you have concluded that you need an antibiotic for your recurrent bronchitis or for your bad cold.
Right,
Your job is to articulate your complaints and concerns to me as fully as you can. And when I propose a treatment plan, if you know you're not going to do that, you can't just yes, yes, yes me at the moment. You have to say, well, I don't really see that working for me, Drew. And we have to hash out something that we can do together. So that's what has to happen. Whether it will happen or not, I don't know. But the payoff is tremendous. What I loved about doing the research for my book was some of the stuff I came up with. There's study after study after study that shows that people who become more engaged in their healthcare, become more knowledgeable about their conditions, they are subsequently more adherent to their treatment plans, and their mortality rate is cut in half. Well,
wow,
if it was 5 or 10%, you say, well, that's an interesting finding. I wonder what that means. Literally cut in half. It's not a single study, it's study after study. By nature, they're observational studies because you can't take 100 people and give half of them the right treatment, and half of them the right advice, and half of them the wrong advice, and see how they do.
right,
But what was interesting about the studies, they're placebo controlled. People who are more adherent to their placebo were or the conclusion in this one article was people who were less adherent to their placebo were 2.5 times more likely to die over the course of a year than people who are more adherent to their placebo.
the placebo.
The
Okay,
placebo, the placebo.
wow,
So, because my first cynical response was, well, that's just saying you take good medicines, they work. So big
right,
deal. You take placebos and they work too if you're committed to the process. If you
right,
made that connection, if there's trust there, if you have optimism about getting better because you know your doctor, you trust your doctor, and you feel like your doctor knows you.
right,
So I mean, that's soft stuff in there. They're observational studies because you can't do them. When people have pointed that out to me, I say, well, name me the authors and the title of that article that showed that. First of all, I say, do you believe that smoking is a risk factor for lung cancer? And everybody says yes. And so, well,
hmm,
when did they publish that randomized placebo-controlled study showing a
right,
group of smokers and non-smokers and how they did better?
right,
You can't come up with it because there is no such thing, because you cannot ethically randomize people to, you got to smoke 3 packs a day. You have to
right,
smoke two, you smoke one, you don't smoke any. You just
right,
can't do that any longer.
right.
Yet everybody believes it's an observational study. So these are observational studies which have that inherent weakness, but
No,
they're
but I think that's very powerful. I mean, absolutely, that's powerful. So let me close with, we need to know, and I'm going to put this in the show notes for everybody, the title of your book, and if someone wants to reach out to you for more discussion or look you up or read your book, how do they contact you?
well, I'm on both Facebook and LinkedIn. I think you probably could butcher Remignanti pretty well, and then some version of it will come up. People come up with Remington a lot because IGN doesn't make a sense as ING. I had one patient after I introduced myself, he wanted to change the whole ethnicity to my name, he referred to me as Ray McNanty. Like, you know, that Irish doctor McNanty, Ray
Yeah,
McNanty.
yeah,
But
perfect.
so, but if you put I let people email me directly if they want, which is much easier because it's drewremy@gmail.com. Anything I've said you find provocative or interesting enough that you want to ask a question or complain or say, gee, I think you're off here, Drew. I'd love to hear it. I have an open mind to hearing.
All right, and we can find your book on Amazon?
It's on Amazon. You get a better deal buying from my publisher, which if you can spell out the full access to my book, or you can find the links to my book on both Facebook or LinkedIn. If you get to Drew Remignanti, just put REMIG, it'll come up.
Okay, and I'll link that for everybody, so they'll anybody listening to this podcast, either on Spotify or on LinkedIn, we'll link it there to find you much easier.
The book is on Amazon. I'm encouraging people to buy directly from the publisher because I talked the publisher into doing something that if you buy the print copy of the book, you get the ebook copy for free.
Ah,
And the nice thing about the ebook is, given that I knew I was going to be speaking to medical professionals and hopefully medical students, and I wanted them to question the crap I was saying, or it's stuff that sounded like crap. I wanted them to say, well, Drew, is Drew making this crap up? I have 280 plus references, 250 which have hyperlinks to the original sources.
wow.
So I would read the physical book, which I prefer to have a book in hand when I read because I'm an old guy. And you can have your phone, your any kind of e-reader with the Kindle version. You don't have to have a Kindle device. You click on that number on the Kindle device and it takes you to the original source to show you that I'm not making things up, because I'm making some pretty bold claims about cutting your mortality rate risk in half.
Right. No, that's great. We really appreciate you coming on today, Dr. Reminanti, and everybody have a great rest of your day.
Hey, Stephen, thanks so much for having me on. I really appreciate it.